is very common in the pediatric age group. Hence, we need to know whether is it different in terms of the clinical presentation, management, if we compare the pediatric and the adult age group. Okay, so we have Dr. Nirmala with us to talk about AD in the pediatric age group. So Dr. Nirmala is a consultant dermatologist, pediatric dermatologist in Hospital Tunku Aziza. She's also an honorary lecturer at UPM. Yeah, I didn't know that. So she graduated from Manipal, India, and obtained her MRCP Pediatrics in 2011. And then she did pediatric dermatology subspecialty training in HKL in 2016. And eventually she went to Westmead Children's Hospital, Sydney in 2018. So apart from covering Hospital Tunku Aziza, I think you do some private sessions as well. Which hospital again? Abisena and KPJ? Kajang? Plan. Alright. Okay, so without further ado, let's welcome Dr. Nirmala to cover the topic on approaches for management of pediatric patients with diabetes.
Thank you very much. Thank you, Dr. Nazra, for the introduction. And thank you, thanks, Sanvi, for having me here today to be able to share this talk with you. So I think most of you are familiar to me. I've seen you somewhere around when you come to HTA for your attachment peads. And this is, I think, added on because of the amount of pediatric dermatologists that is very rare around. Okay, so most of you will be sent to centers where you do not have any support from pediatric dermatology side. And that's when you will need to manage cases by yourself. And some of the things that I'm going to go through here with you is a repetition of what Dr. Evelyn has just given us just now. So I'll just touch briefly on it. She's done a wonderful job by breaking it all down. And I will just add on a bit or two and also finish off this presentation with some basic facts. The objectives of today's talk is actually to describe to you the burden of atopic dermatitis in pediatric patients, who they are not only themselves but also to the parent and the caregivers. Also, I'd like to summarize the systemic therapies that are approved for use in atopic dermatitis. We will review some clinical trial data on the use of biologics in pediatric population, alright, and what are the new emerging therapies that are there. And I'll finally sum it all up with a case discussion on the use of dupilumab in pediatric atopic dermatitis cases. So this is my disclaimer. So let's look into firstly the aspects of the disease burden. Okay? So how common is atopic dermatitis in children, right? So when we ask that question, we look at this. So this is an EpiCare survey that was done over the children who were at North America, Latin America. They covered Europe and also Arab countries here. And they took quite a fair amount of patients. There was almost about 66,000 patients that were covered. And what they saw, you can see highlighted here in red, was those cases where the prevalence was more than 15%. You can see all these countries here. But if you take the overall prevalence by age group, you can see that as young as 6 months to 5 years old is 12.1%. And it doesn't get lower, it just gets more and more over the years. Over 6 to 11 years is 30%, and over 12 to 17 years it goes up to almost 15%. Okay? So the prevalence is actually increasing. And if you take a point prevalence of atopic dermatitis in adults, what you see is it's just 2 to 8% compared to what the levels we see in children. So then again, it's very, very common. So these are the morphological distributions that we see in children. So in infants, 6 months to a year old, this is what we classically see. It affects the face, the extensors of the limbs, the trunk, and it has this characteristic sparing of this diaper area. Okay, so this is what we see in infants. But in older children, what we see is they have different types of skin lesions, particularly affecting all the flexural folds. And in adults and adolescents, it's the same. They can affect the wrist, ankle, eyelid area, upper trunk, shoulders, and scalp. So if you look at the early onset, okay, like we said, it can be as early as 6 months old. And we see that almost 85 to 90% of the patients develop by the age of 5. So this is a huge number, right? And they tend to persist into adulthood. If we look at the risk factors, what causes them to have persistence to carry forward into adulthood, we see that if the onset of atopic dermatitis is earlier, okay, lesser than the age of 2 years, if it has got greater severity of atopic dermatitis, in those who have atopic dermatitis that lasts more than 5 years, and in those with strong family history of atopic diseases. So these are the risk factors for the child to have persistent atopic dermatitis later on in adulthood. But when we take and look at the proportion of patients who outgrow this disease, that's what we say most of the parents, right? Like, don't worry, your child has atopic dermatitis now, but once they become bigger, it will get better. But actually, there is a conflicting studies that say that if we take the systemic review and meta-analysis of about 45 studies that was done, taking into account about 110,000 patients, and this was covered over 15 countries, they said 80% of the childhood atopic dermatitis did not persist beyond 8 years. So this is good news for us. So most of it gets settled when they're childhood. But then again, if we look at this pediatric eczema elective registry that was done in US, they took account into 7,000 patients. And what they found was that at every age, from 2 to 26 years old, more than 80% of them had symptoms of atopic dermatitis, were either on medication to be treated or had the symptoms. So it was like conflicting both sides. They're saying they were overcoming, at the same time they saw that the patients still had persistent atopic dermatitis in adulthood. So if we look at in children and in adolescents, what we can see is it starts off much earlier on, infant and toddler age. The most dreaded complication is, of course, pruritus. Because of the atopic dermatitis, it disturbs the child a lot. Because of that, you have the sleep disturbance, and you have other associated atopic comorbidities like your asthma, your allergic rhinitis, and other associated food allergies. They are very prone for viral and bacterial skin infections. And it's not only a burden to the child, it's also a burden to the caregiver, right? So they have restrictions, they have sleep disturbance, they have to care for the child. And this continues on as the child grows. So you can see as the child grows, they have other associated problems such as your mental health and psychological impact. They have the social embarrassment and shame. They have impaired school performance and increased risk of low bone mineral density. So if you look at the most dreaded complication of atopic dermatitis that they suffer from is itch. So if you were to take the children, and this was a survey done, they found that 60% of the children with moderate to severe atopic dermatitis gave an overall itch rate of 7 to 10. So that's quite bad, right? And 30% of these children with severe atopic dermatitis said that they felt overall itch being 10 out of 10, the worst possible itch imaginable. So imagine 30 of them feel that it's almost 10. And if you look at the severe, mild, moderate, and severe, what they found was they said that they feel itchy multiple times a day. When it's severe, almost all of them said that they felt itchy all the time. For moderate, they said about 40%, and for severe, of course, it's 100%. And what they found was they had marks and scars due to the scratching, which was persistent in all, from mild, moderate to severe eczema. And when we take into account of age, how did it disturb children? They found that 23% of them had problems attending school, they had problems concentrating, and they had mood swings, right? And 37% of children found this disease very debilitating, and they also thought that it was unpredictable. They do not know when they're going to get the next flare. And most of the time, these children, almost 70% of them said they had difficulty staying asleep, they had difficulty falling asleep, and they were always frequently woken up from sleep. So this was all just because of the itch problem. If we look at the sleep disturbance, you know we're dealing with children and with adolescents. You know they sleep a lot, right? They need the rest. And what they found was those with mild, moderate, and severe, not surprising, those children with severe, almost 80% of them had severe sleep disturbance. So now this sleep disturbance affected them how? That they had problems with neuropsychiatric impairment, they had depression problems, they had anxiety, and they had inattention at school. With insufficient sleep, Children also associated with reduced vertical growth and increased risk of fractures. Okay, would you agree with me on this? So they don't sleep, they don't grow much. Okay, and also because of this eczema taboo, when they say it's always related to food, they say that the parents will always restrict their diet. Okay, so that all leads to this increased problems that we see. They have reduced growth, and there's no difference between racial groups were seen in the study. Okay? Not only do they have problems itching, sleep, they also have these type 2 inflammatory disorders that come together with the eczema. All right. So they either have this allergic conjunctivitis, this chronic nasal polyps, they have asthma, they can have urticaria, eosinophilic esophagitis, and very, very commonly, almost 50% of them have this allergic rhinitis. They can also be associated with other type 2 comorbidities. Okay? So what are the risk factors that are associated with these atopic comorbidities? Okay, so that is increased atopic dermatitis severity. The more severe eczema that they have higher tendency to develop this. Earlier age of onset, parental atopic history, polysensitization, and also, if you look at the gene mutations, filigree gene mutations are very prone. Okay? So we all know that pediatric atopic dermatitis is associated with food allergy, psychosocial comorbidities, they have allergic contact dermatitis, they have other problems such as growth impairment, they get also occasionally autoimmune diseases. Not surprising, they end up with having alopecia areata. I'm sure you've come across that as well. Okay, and other comorbidities besides conjunctivitis. So here is a forest plot that shows the various studies that were done, which showed the association of osteopenia in adult patients who had atopic dermatitis, and that was significant. The same results were seen for the risk of osteoporosis in adult patients with atopic dermatitis who had these problems. Okay, so it is to say that this atopic dermatitis not only affects the skin, it also has systemic manifestations as well. Okay, when they grow into adult. Well, another very common complication that we face with children is infection. Okay, somehow or other they cannot control their itch. They tend to itch their skin, and then they have this wound, and they get very commonly staph infection. They can get viral infections such as your eczema herpetica, your eczema coxsackia, and also not forgetting your fungal skin infections. And these fungal skin infections can persist for months altogether, right? And sometimes we do treat them with oral antifungal for months, okay? Weeks to months, okay? To just get rid of it. Not forgetting, we know the commonest colonizer of the skin is your Staph aureus. And children and adolescents with atopic dermatitis have an increased risk of systemic infection requiring hospitalization. So this is another major problem that we see. Most of the time they get admitted because of infection. They have other type 2 inflammatory diseases, like I told you earlier on. They can have asthma or rhinitis, and they have increased risk of systemic and cutaneous skin infection. Now, that was just looking at the child. What about the caregiver? Now, in children, in pediatric population, they are a bit special. They do not come for appointments themselves. They do not know how to apply medications themselves. They're so dependent on their caregiver, their parent. So this was a survey done on the caregivers. They asked simple questions, okay? So looking into the domain of sleep, their social isolation, the time requirement, what about their family relationship dynamics. So they asked simple questions, and what they found was actually quite shocking. 82% of the time, the caregivers were actually worried that child might end up having a flare. That was at the back of their mind. I don't know when my child is going to get a flare. They were worried about the adverse effects of the atopic dermatitis on the treatment that was given to the child. This is 76%. But then again, in this era where there's steroid phobia, the most important question that they ask you is the child's skin going to thin? Is it going to affect this child's growth? So on and so forth. So if they have this at the back of their mind, they also feel a sense of helplessness, okay, and guilt because the child is suffering. They find it hard to do what they enjoy, and the child's atopic dermatitis actually affects the whole family's social life. Okay, work is again affected. They have to take time off. They have to bring the child if the child's hospitalized or if the child needs a checkup. And they find that almost 50% of them say they are dissatisfied with the help they receive from the medical professions. And some of them, like almost 50 of them, say they feel sad and depressed because the child has atopic dermatitis, and they also feel blamed or judged that they are not doing their best for the child. Okay? But if we take into the perspective of the child, we see that almost 50% of them are depressed. Okay, so you can see in my clinic when they come, they are sad, they look unhappy, alright, they've not slept, they look unkept, alright. Patients with a school or work life that is affected, almost 45%. They are very concerned about being seen in public. They have got low self-esteem, alright, they are bullied, they are teased in school, they have reduced self-confidence, and they also have to have time off from school because of their illness. Right? So let's move on to the next portion of my talk, that is the systemic treatment for atopic dermatitis in pediatric population. So I want to take your attention to this slide. Okay, this is quite an important slide. So if you see in pediatrics, we are almost 10 to 15 years backwards compared to adults. Okay, in coming to treatment of atopic dermatitis. The most important question that we keep asking ourselves is this drug safe? What is the youngest age group that we can use it on? What are the side effects and what's the cost, right? So, over the years, what we have been doing is, you all know that this is the conventional systemic therapy that we use. We have used methotrexate, azathioprine, MMF. We also have used lots and lots of children on cyclosporine, okay? Because just topical corticosteroids alone don't help, okay? And we also use quite a lot of systemic corticosteroids, not just for bridging, we also use it to control acute flares, okay? Especially when they're admitted and having severe acute flare. So I know that Dr. Ibn shared the slide earlier on. She said it's not recommended for children less than, what was the age we gave? 2 years, if I'm mistaken. But then again, we do not use all this on children less than 2 years, but definitely more than 2 years we've got no choice. We do use this quite often, right? So this was what we were doing prior to the introduction of dupilumab, alright? So you can see dupilumab, it acts on interleukin 4. It is approved for use in severe atopic dermatitis in children as young as 6 months to 11 years old. And tralokinumab, it acts on interleukin 13. This is on phase 2 trial still, okay? It's expected to be completed in August 2024 for use in children 2 to 11 years old. In lebrikizumab, we have a phase 3 trial that's going on to be used in children 6 months old to 17 years old, but this study is expected to be completed in July 2025. As for nimolizumab, we have a phase 2 study that's going on, which will be ready in 2025. But for use in children who are adolescents, 12 to 17 years old, we don't have a problem. We have most of it approved here, okay? It is just that this age group of 6 months, these infants, 11 years old, that we have some problems here with. Again, if we look at Upada, our JAK inhibitors, it's on phase 1 trial still, which is expected to be completed in 2024. And Abros not yet, and this again, Bari, yes, but 2 to 17 years of age. So we go quickly into Dupi. So Dupi, you know, has been, this is the pivotal study for Dupi, our Liberty study, where they have done phase 2, phase 3 trials, and initially it was 8 weeks. They looked into the safety and the pharmacokinetics of children more than 6 months to less than 6 years old, and then they went on to 16-week monotherapy. And what they did was they used it as monotherapy. They used it with topical corticosteroids, not only in adolescents, but in children, and also they extended it to infants as young as 6 months old. And all this has gone through your phase 3 trials, and they are being used in US. Okay, so in Malaysia, what we're doing is we are using it for children 6 years to 11 years old, but we are not yet here. Okay, so when we say we're using it, meaning that it's already in our blue book, right? So we're just waiting for the approval for it to be used here. But frankly speaking, I do use it for children less than 6 years old, lots of them. but we use it as off-label use because it's not there yet in our book. So this is the Liberty preschool study. So this is for 6 months to 5 years. So what they did, they took kids from 6 months old to 5 years who were inadequately controlled with just topical therapies. They had an IGA of more than 3, they had an EASY score of more than 16, and they had a body surface area involvement of more than 10%. So they randomized it into 2 groups. One was placebo with topical corticosteroids, and the other one was dupilumab, and they saw the primary endpoints at 16 weeks. So this was it, what they saw for these children. You can see improvements as early as 4 weeks, and was sustained over at 16 weeks, almost 50% of the patients easily achieving EASY 75. And the same thing goes for your itch. You can see working wonderfully as early as 2 weeks, 2 to 3 weeks, and you can see it being sustained over 16 weeks. This is looking into the infant dermatological quality of life score. You can see it's statistically significant compared to your placebo. Same thing goes to your childhood. This is looking into the mean % change of your EASY score at week 52. So you can see it was 50% over baseline at 16 weeks. It was sustained and carried down almost 87%. You can see at week 52 it was sustained, right? And you can see the mean change of childhood dermatitis quality life index. You can see again fantastic improvement. You can see at week 52. What about patients 6 to 11 years old? Again, very good results we see with patients achieving IGA of 0 to 1. At 52 weeks, it's sustained, it carries on, and it can achieve this at 52 weeks. The same thing we see of patients achieving EASY 75 as quick as 2 to 3 weeks, and you can see it being sustained up to 80% at 52 weeks. This is looking into adolescents. I think this one I won't touch much. Again, very good results. 50% and here 86%. This is looking into children with severe AD and the improvement they see with placebo. You can see that children aged 6 to 11, you can see a very, very significant amount of changes you can see occurring as quick as 2 weeks, and it is carried on till 16 weeks. Okay, you can see the reduction here. Again, in older children, you can see quickly working as early as 1 to 2 weeks, and it is sustained carried out to 16 weeks. And it is seen in both groups. Okay, so in those receiving dupilumab 200 milligrams and those receiving dupilumab 300 milligrams. So what about the side effects? So every time we put a child on dupilumab, the question that the parent wants to know is what are the side effects? Okay, so there were no any reported adverse events seen in the dupilumab group compared to your placebo, and the common side effects were almost the same in all the groups. And you can see the most commonest one that we see in dupilumab is your nasopharyngitis a bit and your conjunctivitis. Okay. Okay, this is looking into your tralokinumab. Now, if we look at tralokinumab, this is the pivotal study, your extra. What they did was they put the children on this 52-week phase 3 trial that's ongoing. There's 2 groups, that's 150 milligrams and 300 milligrams versus the placebo. They had 300 children, adolescents aged 12 to 17 who had moderate to severe atopic dermatitis. At week 16, they found that tralokinumab group met all the co-primary and secondary endpoints, and they also looked into the SCORAD score, the dermatitis quality life index, and they looked at the 4-point improvement in your itch. Okay, the safety results were quite comparable to the adults, and the incidence of conjunctivitis as the reverse side effect was same across all the treatment groups. You can see here, right? So again, remember this is older age group, 12 to 17. Now we look into the adverse effects of seen with tralokinumab. The dupilumab. This is a trial of lebrikizumab, okay, use of lebrikizumab in adolescent children 12 to 17 years old. This is again an ongoing 52-week phase 3 trial. They recruited 800 patients, and lebrikizumab was given 2 weekly or 4 weekly, but the dose was not yet reported as of now. The primary endpoints were the same. They looked at EASY 75, they looked at IGA, and they also looked at the age score. Now, the important thing was that the primary and all secondary endpoints, such as your age, interference of age on sleep and quality of life, were all met at 16 weeks. The safety profile, again, in children 12 to 17 years old were consistent with the other studies that were done with adults. Next, we move on to JAK inhibitors. Again, compared to biologics and JAK inhibitors, most of these JAK inhibitors are only approved for use in children above 12 years old, right? So, this is the pivotal study for baricitinib. So, we looked into this BREEZE study where they took children as young as 2 years old till 18 years old who had moderate to severe atopic dermatitis and who had an IgA of more than 3, they had EASI score of more than 16 with more than 10% body surface area involvement. So what they did was they divided them into these 4 groups. There was a placebo with topical corticosteroids, baricitinib low dose, medium dose, and high dose. So for those of you who need to know a bit more, those children who are less than 10 years old, the low dose means it's 0.5 milligrams, medium dose is 1 milligram, and the high dose is 2 milligrams. But for those children who were above 10 years of age, this was 1, 2, and 4 milligrams. Okay? So that was the age cutoff. And what they found was very, very good improvement, right? You see with baricitinib, you can see almost 52% of the children at the age, at the week of 16, they were able to achieve this. But as you can see, those who are taking baricitinib, the lower dose, you can see it's almost comparable with the placebo. So the higher dose of baricitinib worked better. Right? Same thing here, if you look at the proportion of patients achieving EASI 90, again, 30%, this is the high dose for the baricitinib, but when you look at the lower dose, it's almost comparable with the placebo. Okay? This is the proportion of patients achieving the IgA of 0 or 1. You can see it starts working as early as 4 weeks, which is statistically significant. Very good improvement you see at week 16 with the high dose of bari, whereas the low dose is almost comparable with your placebo. This is looking at the itch score. Again, fantastic improvement you see as early as 3 weeks, and it is sustained, and you can achieve almost 35% of the patients achieving good control. As for the side effects, right? So there were no any adverse side effects that were seen comparable to your placebo, and the infection rate was almost the same in all these groups. There was no any discontinuation, and there were no any serious adverse events. However, you know, as we start JAK inhibitors, we have to do some blood investigations, right? So for that, if we look at your full blood count results and all is fine, it's not much of a difference, but the cholesterol levels were slightly high. And we noticed this, especially in the baricitinib higher dose. The higher the dose is, they were involved with this thing being higher, right? As for your creatinine and your CPK, they were almost comparable in all groups. This is the pivotal study for abrocitinib. J18 study, you can see very good response as early as 4 weeks, and it is sustained as early as 12 weeks. You can see very good results of almost 46%, okay? They can achieve IgA 0 to 1. What about EASI 75? 72% of the patients can achieve it by week 12. Very good results here. And as for your itch score, again, almost more than 50% of them can achieve it, okay? As early as 12 weeks. What about your more than 4-point improvement in your POEM score? Again, when we compare both groups, you can see very good results on high doses. You can see 83% here. Compared to your J18 and Mono 1-2 study, you can see they are more than 70%, okay? Improvement seen. What about the side effects? So we look at the side effects in children, what we saw was that the most commonest one is your nausea that they get. But again, you notice here that the higher the dose of abrocitinib, you can see it is higher. And same goes for your dizziness here and your vomiting. So if they do encounter this, it's advisable for you to cut down on the dose. Okay, your eyebrow. What about your upadacitinib? So for upada, again, this is the pivotal study, you measure up 1 and 2. And what they found was that they took the 16-week trial on 228 adolescents. They looked for the primary endpoints at 16 weeks, and they were given in 2 doses, either 15 or 30 milligrams, and the endpoint was it was consistent between the adolescent and the adult patients. As for your atopic dermatitis UP study, again, they took their primary endpoint at 16 weeks, and what they found was that upadacitinib was statistically significant compared to your placebo, okay, as early as 16 weeks. So efficacy in adolescent population was again consistent with the overall population. Okay? So in summary, we know that atopic dermatitis frequently impacts the mental health, not only the children, and also the well-being of the caregivers. Now, dupilumab was the first monoclonal biologic to be approved for use not only in adolescents for moderate to severe atopic dermatitis, but also in children as young as 6 months old. Okay? And you know that they have been approved for use in US, in UK, and also in Europe. Additional treatments have recently become available for this adolescent group above the age of 12 for moderate to severe atopic dermatitis, with the approval of JAK1 inhibitors like your abrocitinib, upadacitinib, which is currently being used in UK, in Europe, and also in Japan. Okay, there are ongoing phase 3 clinical trials for your interleukin-13, such as your tralokinumab and your lebrikizumab. They suggest actually good efficacy and safety in adolescents with moderate to severe atopic dermatitis, but the full clinical results have not yet been published. Okay? Pediatric clinical trials are currently ongoing for your nemolizumab and your JAK1 and 2 inhibitors, such as your baricitinib, but still it is not yet available for use in pediatric group. And what I mean by that is less than 12 years old. Okay, next we move on to some case discussions. I would love to share more cases with you, but these are the 2 cases that I picked up. At present, at HTA, we have almost about 55 children who are on dupilumab, and almost half of it we've managed to actually taper them and off. Yeah, I know this question was asked earlier on, so almost half of them are off already, just the other half that's still ongoing. And we do, prolong the injection doses, sometimes as long as 2 months. Okay, so they just come every 8 weekly to just get an injection and go, and they're perfectly well in between. Okay, so we do not stick to this 2 weekly one. I know that's what's recommended, but in our practice is what we do because of the cost problem, right? So let's look at this case. Now, this child is a 6-year-old boy. He had eczema at the age of 1. He has a very strong family history of atopy. Both his parents have got asthma and also eczema. Initially, he was well controlled with topical therapy, but since the age of 3 years old, he developed multiple flares. Okay? He required oral steroids, and also his concentration of topical steroids were increased. He was on cyclosporin. He was also put on azathioprine, each for a year, but there was not much improvement seen. He was actually compliant to the topical medications. There was history of frequent admission to the hospital the last 2 years for infected eczema. His EASI score was actually 53, and his itch score was almost 9 to 10 with poor sleep. So this is how he presented to us. This is his front. You can see overall it's erythrodermic. You can see it's very lichenified, it's very scaly and dry. This was his back. Okay, you can see it's very lichenified, it's very thick. That if you were to grade this, I don't even know how much do I give this. 20, 30, I'm not sure. It's so thick that none of the potent topical steroids were able to actually penetrate through this. Okay, this was his lower limbs. Again, very dry, scaly, lichenified, and you can see almost the whole lower limbs affected except for the feet. Right? So we put him on dupilumab because we actually had no other choice. Okay, we didn't know what else to do. Okay, and though at that time dupilumab was only available for use in children above 12 years old, we still used it off-label for him. Okay, he was 6 at that time. So we used it, and we saw response as early as 4 weeks. Okay, so his itch score just plummeted down, and he was able to sleep better. He was playing. He was becoming more normal. But to be very honest with you, it took us almost a year for us to actually control, bring it down to a normal child. Okay, so this is how he was at 52 weeks. This was his lower limbs, all right? And this is how he was. You can see, right, just from this, you can see that, he was very thin and scrawny, this child. You can see just over a year, you can see he's put on a bit of weight. You can see he's appearing more healthy, right? But this is his back, and this was how it was, okay? At 52 weeks. Now, what is the aim? I cannot be continuously using dopilumab until he's adult, right? As long as if I can achieve this, I can switch it over to topicals. That is my aim, right? With this, I cannot do anything. I can't just keep him on any topicals at all. I've tried red wraps, and phototherapy doesn't work with children, okay? I cannot put a 6-year-old boy in a cabin, locked there, and tell him to stand there like this for 3 times a week. There's no way it's going to happen, right? So we don't have much choices. And so that's when we were so desperate that we went to this, and that was the results we got. So I'll go on another case, where this is an 8-year-old girl. She had eczema since the age of 3. She was put on potent topical steroids, but her problem was different. She had a severe nodular prurigo. Okay, it's very itchy, very hard nodules. She was on high potent topical steroids, and also we started her on oral cyclosporine for a year. Can you see the hypertrichosis? All this is the side effects, right? But we had no choice. But again, despite of doing all that, she still had this problem going on. She couldn't concentrate, she couldn't sleep, she was very depressed. So then we decided to start her dopilumab. So this was her lower limbs. You can see how bad it is. She couldn't even wear her school shoes. She had to go using slippers to school and things like that. So after 16 weeks, right, on doping, this is what happened. Her back. Alright, we managed to clear it off. She was just maintained with just emollients. And this was the lower limbs after 16 weeks of treatment. Okay, so you can see all these were just post-inflammatory hypopigmentation. Alright, so these are the 2 cases I'd like to share with you. They were different, totally different spectrum, where it's not the normal atopic dermatitis that you see. Alright, in my private practice, well, I do use Dupi. In those patients who can afford it, I don't wait for them to get moderate to severe. Okay, so you have this affluent group that comes to you. The child just has mild atopic dermatitis, and they do ask to be put on this because they don't want the child to be on steroids. Okay, so this thing about steroids in children is a big no-no. It's well publicized in your Facebook, and they have these groups, right? So it's very difficult to convince them otherwise. I can't be applying my TCIs on all the other areas, right? So yes, I do use for mild, but most of the cases, it's when it's already moderate. I know that my topicals are not touching them, then I go into Dupi, right? Okay, any other questions?